I want to apologize to everyone who attended our webinar last week. As a result of technical difficulties with the platform, we had to reschedule the event to assure a seamless experience. As I said last week, note, this is part one of a two-part series, which will be conducted by myself and my dear friend and colleague, Dr. Jania Johnson. Part two of the trauma series will be held tomorrow at the same time, 2 p.m. Eastern Standard Time. As a researcher and as a practitioner, this topic is near and dear to me. I spend a lot of time thinking and writing about the effects of trauma. In fact, my most recent article was just published a few days ago in Harvard's Medical Journal of Adolescent Psychiatry. Many of the concepts we will discuss today are also featured in the article as well. If that's okay, I will include the citation to the article in the chat box for you to review later for further reference. Just a few days ago, next slide, just a few days ago, Sunday to be exact, the issue of trauma and its effects on healthcare workers took a drastic turn. 49-year-old Dr. Lorna Brand committed suicide after presenting symptoms of trauma and PTSD after weeks of exposure to traumatic deaths while treating COVID-19 patients. According to Dr. Brand's father, she didn't have any history of mental illness prior to COVID. However, after weeks of working with the COVID surge, she became bombarded with intrusive thoughts of patients dying, anxiety, and other mental health conditions. What scares me most about Dr. Brand's story is, unlike most Americans who actually have underlying mental health issues, she didn't. To me, this begs the question, what happened? What happened there? And how do we prevent this from being a new norm? Although the webinars managing trauma for the healthcare professionals, at the core of what we're going to explore today is the relationship between what we think and what we feel, and how what we think and what we feel further impacts who we are and the things that we do. Take a moment and read the quote on the screen, if you would please, and then ask yourself, what does it mean? What comes to your mind when you read the quote? So if you would, please take a few seconds and share your thoughts in the chat box. For those who are just joining us, we're reading the quote here on the screen, and I've asked the audience to take a few seconds and to reflect on the quote and just ask yourself, what does it mean? How does this quote on the screen resonate with you? What comes to your mind when you read, I cannot do all the good that the world needs, but the world needs all the good that I can do? What comes to your mind? What do you think of when you read that quote? And so I'll give you just a few seconds to put a couple comments in the chat box, and we'll pick up and we'll move right along. Right. So someone said that they're most sad that as a recent grad, that they don't feel that their campus has reached out to us to ensure that they're okay. And so what you're feeling is very normal right now. And we'll talk about that later in this webinar. Thank you for sharing. Again, thanks for sharing your thoughts about your experience and sort of how this quote sort of resonates with you. When I read the quote, I think about the tragic story of Dr. Brand and sort of this juxtaposition that many healthcare professionals find themselves in when trying to balance what they can do versus what they can actually give. And although I didn't know Dr. Brand, I would hypothesize based on my professional experience that she struggled with sort of managing this balance of what we were being asked to do, or what she was being asked to do, what she was being asked to do, rather, I'm sorry, and what she was actually able to give during those moments. And what's interesting, based on my experience, I know that many of you are thinking that this process, in terms of this juxtaposition, that this is a simple process. I know many of you are thinking, oh, Gil, this is not hard. This is easy to do. And Gil, this could never happen to me. And I would also imagine that many of you are also asking yourself, well, why didn't Dr. Brand just leave the job when things got so intense? right? I'm sure many of you are just asking yourself, hey, if it would have been, or saying rather, if this would have been me, I would have just walked off the job and I just would have been done. I would have took a vacation. So I know that it's very common for us to have those questions during these times. But from a psychological perspective, I would like to just give you an analogy, if I could, that might just sort of provide some insight into why it is that those who are working on the front lines simply cannot just walk away, and why trauma becomes so overwhelming. So just work with me for a second here. By way of analogy, think about this for a second. If you boil a pot of water, right, and you have this hot boiling pot of water, if you drop the frog in that water, immediately that frog is going to jump out. He's going to jump out immediately after experiencing the temperatures of that water. However, if you place that same frog in a lukewarm pot of water and you slowly heat the water to a boil, the frog will surely die in the boiling water. And so you ask yourself, well, why? Why is it that if you put the frog in this hot boiling water initially, the frog would jump right out, opposing to if you put this frog in this lukewarm water and slowly let the water come to a boil, why would the frog die in the water? And the answer is simple. Because the frog will slowly start to adjust its body temperature to the water, and to the point to which it's too late. And so the frog will attempt to adjust its body temperature to the water to accommodate for its environment. But by the time the frog realizes that the temperature is too hot, it's too late. And so many of us, we think that because we have maybe 10, 15 years of experience in the field, that it will inoculate us from trauma. And it will not. To leave the water is counterintuitive to everything that we've been trained to do as professionals. So when we get tired, we go and drink coffee, right? When we're tired, we make those adjustments. We drink coffee. And we're having those long days, we turn to our patients to give us strength. Hence, we adjust. We became healthcare professionals because of our innate predisposition to serve and want to help people. I always say firefighters run into burning buildings, not because they want to die, but because their training and commitment to their profession is greater than their fears. Although the right thing, asking a nurse not to treat a patient in desperate need of care because of insufficient PPE, and again, that's the right thing. But it will likely appear counterintuitive to their personal and professional development. And most importantly, it might appear counterintuitive to their personal oath. Next slide, please. The first 2 to 3 weeks of the COVID crisis, we all heard the heroic stories of nurses and doctors and other healthcare professionals working 24 to 36-hour shifts without taking a break, some of them without even going home to see their families. We all heard the stories of policemen and firemen serenading, in many cases, the hospitals. And we cheered and praised their efforts because we knew that what the nurses and the doctors and social workers, respiratory therapists, we knew that what they were doing was extraordinary. As I watched the nightly news and read the headlines, I was also in awe of the bravery of our healthcare workers. However, as time began to pass by, my perception of the brave workers started to change as I started to view their efforts through the lens of a psychologist and as a researcher. And for me, I think it was at that point that I started to watch these heroic efforts with sort of bated breath, knowing that what goes up, eventually it's going to come down. Fast forward 3 weeks later, and now we're here. So stay on this slide just for a little bit here, please. So if you fast forward, now we're here. As the days and weeks have started to pass, the long hours, the isolation, and the constant exposure to death and despair has eventually reached its peak. And now things are starting to break down. After weeks of intense stress and unimaginable conditions of our systems are nearing the breaking point. And unfortunately, the lines between the helper and the helpless are slowly starting to blur. In the case of Dr. Brennan, all the PPE in the world could not have saved her from entering the dark places before her death. Today, our enemy is no longer just a virus. It's the malignant trauma that resides deep inside of us. It's the inner battles between our ears, led by intrusive thoughts of death, anxiety, and severe clinical depression. The question is, might Dr. Brand's story be a foreshadow of what is to come? Next slide, please. A recent national study released by FedTrail in partnership with Halabu revealed that 74% of nurses report experiencing high levels of emotional stress and anxiety. So just think about that. 74% of nurses report experiencing high levels of emotional stress and anxiety. 61% said they are likely to leave their current position of specialty. And 67% of participants said they are planning to either leave their facility or industry altogether. Next slide, please. So one of the most effective ways to reduce the impact of trauma is to be able to anticipate and to an extent predict with some level of certainty the emotional highs and lows, right? In the context of COVID, the best way to do this is to view COVID sort of through this emotional phases, through this crisis phase. And so when I think about the ebb and flows and the emotional reaction to COVID, I see a very predictable pattern or behavior pattern. And as a result of that, I would like to show you and sort of illustrate by way of illustration the 4 emotional phases to a crisis. And so if you look at the screen closely, you'll start to notice, I'll talk about the emotional phases of crisis, but I'm going to talk about them in these 4 different phases. And so the first phase is the heroic phase, right? And so this phase occurs directly after a disaster. During this phase, heroic actions are taken to help people recover from and or survive a disaster. Then we sort of transition to the honeymoon phase. In this phase, people draw together to solve problems and this sort of intense showing of community. This phase generally lasts from 1 week to 6 months. Then we have the disillusionment phase. In this phase, people begin to become overwhelmed by the event and questions regarding safety, processes, and the extent to which reward versus the benefit starts to enter the consciousness of people. This phase could extend from 2 months to 1 or more years. And finally, we have the reconstruction phase. Here, individuals either work together as a group and make progress or digress and remain stagnated. So although understanding the phases are important, it's more important that we understand the emotional state that are associated with these phases or the feelings that are attached to these phases. So let's take a close look at the screen with me again here. So if you look at the left side of the graph, right, you'll notice the range of emotions ranges from low to high. And if you notice in the heroic phase, our emotional state is very high, only to be surpassed as we enter the honeymoon phase. So to put this in perspective, the first week of COVID, the first week or so of COVID, you can clearly see that we were in this sort of heroic phase, right? And the second and third week, even more clear, you can easily sort of see, if you think back to what was going on that first, second, third week of COVID, you can clearly see we were in sort of that honeymoon phase. And that sort of as evidence all across America. Like I remember seeing police officers, communities, and as I said earlier, and firemen outside of hospitals, thanking healthcare workers for their services. We were in this sort of emotional high, sort of as evidence in the graph. However, similar to what we see in the graph, if you notice, think about sort of current times, we've slowly transitioned to the disillusionment stage. The disillusionment phase are now, you can see our emotional state has dropped significantly. And now you see this sort of divergent path that starts to take shape. And as further evidence, now many Americans are now sort of starting to question the government's response to the crisis, right? While others are now starting to protest, stay in shelter orders that were actually once welcomed by all the communities. So you can see this sort of divergent path as we sort of enter the disillusionment stage. And again, it's important to know this because this impacts our emotions and how we will then respond psychologically to these potential traumas that may be coming our way. So as we transition to the next slide, one of the things I want you to start thinking about now is this whole notion of trauma. Right. So we've talked about the crises. We've talked about this sort of emotional roller coaster. Now let's start talking about how does trauma sort of enter this sort of equation. So one of the questions I'm often asked is sort of how do we get here? And how do we break this sort of barbed wire effect that just seems to restrict the way that we think and feel? One of the most profound impacts of COVID that is not discussed as much is the precipitous nature of uncertainty and how it leads to abnormal levels of stress, anxiety, and depression. We all know that fear causes the body to release cortisol, which is a stress hormone that transitions the body into fight or flight. We all know all that, right? However, what we sometimes forget is the power of uncertainty and how it has a similar ability to paralyze emotional and physiological states. At the core of what we are feeling now is uncertainty, and this uncertainty is leading to high levels of anxiety, which is then leading to fear. Think about this for a second. What did you think? And I want us to separate our thinking and feelings here, but I want you to think about this for a second. What did you think? And then what did you feel the first time you walked in a store and saw empty shelves with no water, in some cases, no meat, no tissue, and all other essential items off the shelf? What did you think the first time when you walked in the store to buy items for your family after getting the stay in shelter orders or just in anticipation of the orders? But what did you think the first time you walked in a store and you saw the shelves were empty? No essential items, all the tissue just gone, right? What did you think? And secondly, what did you feel? For many of us, including myself, the fear was panic. The feeling was panic. And of course, with that panic is that underlying heartbeat. And in some cases, that underlying heartbeat of increased anxiety hasn't subsided yet. And so we have this underlying tension and this underlying anxiety that's continuing to perpetuate. And interesting enough, in a recent study, researchers discovered that participants who knew for sure that they would receive a painful electric shock actually felt calmer and less agitated than those who were told that they only had a 50% chance of getting the electric shock. So again, this recent study recently released, participants who knew that they were going to get a very painful electric shock were more calmer and more poised than those who were told that there was a 50% chance that they were going to get a shock. So basically what's happening here? What's happening is the brain prefers predictability over uncertainty. Predictability alleviates stress and anxiety, both of which exacerbates the symptoms of trauma. So if you put that in the context of COVID, you have C4 in a boiler room. It's that explosive. Next slide, please. So as we transition to our next slide and we start to take a deeper look at trauma, it's important that we understand the impact of trauma because of its ability to change the brain and how our brain functions. Exposure to trauma results in acute and chronic changes in neurological systems specific to the different regions of the brain, which of course results in long-term changes in brain circuitry. There are several different types of trauma. However, for this presentation, there are three that I think that are important of note. Complex trauma, which is exposure to multiple types of traumatic events. Then there's chronic trauma, which is reoccurring trauma, exposure to multiple different types of the same types of trauma. And then there's vicarious trauma, which is indirect exposure to trauma that creates a similar effect as though one was directly exposed. Now, based on our definitions alone, you can see how the different variations of trauma could manifest themselves differently in the lives of different demographics. Let's take complex trauma. Let's take complex trauma, for example. For many of us, COVID is only one of many other stressors that we have going on in our lives. When you combine COVID with other stressors and traumatic events in our lives, for example, like relationship or marital problems, abuse or addiction, you can see how someone suffering from complex trauma might be at much greater risk of clinical depression, brief psychotic disorder, and even suicide, when you compare that to others who might have fewer internal and external stressors. And this is important not just for healthcare providers, but for our understanding of our patients who we might be treating as well. So you can consider the impact of COVID as an extension of maybe a comorbid disorder, which will likely exacerbate many traditional medical and psychological problems that we have become accustomed to seeing and treating. Compared to the symptoms of complex trauma, compare the symptoms of complex trauma with that of chronic trauma, and you can see how reoccurring exposure to traumatic events can lead to what might appear as psychological paralysis. So primarily because constant exposure to trauma transformed the brain from what we call a learning brain into a surviving brain. The surviving brain is focused strictly on surviving and navigating perceived threats, while a learning brain is focused on learning and expansion of skill sets. In all cases, the survivor brain trumps the learning brain. And so that feeling of paralysis that some of us might be feeling, or our patients might be feeling, is truly a symptom of the fight or flight system, which we discussed earlier, which is activated during the active phase of the survivor brain. So think about this for a second, and we'll transition. Think about this for a second. Think about all of the nurses and doctors and other healthcare professionals right now who are working in acute care settings. Many of them are seeing death at unprecedented numbers. We've all heard the stories of nurses praying with their patients as they take their last breath, and nurses and other healthcare professionals having to transport dead bodies into packed mobile trailers because there's just no more room inside the hospitals. So I ask you, what will be the cost of constant exposure to death and despair? Who will bear this burden? So we'll stop and just sort of chat for a little bit and just talk openly. So I'll ask you again, what will be the cost of this constant exposure to death and despair? And who will bear this burden? Please include your thoughts in the chat box, and we'll discuss in just a second. Again, what will be the cost of this constant exposure? And who will bear the burden? How will this impact our profession moving forward? Someone said that we all have to adopt to this new way of life, learning and adopting new skills to survive. And so the question becomes, as we make these changes, where might these changes be implemented? Are these changes implemented in the hospital settings? Are these changes implemented in our curriculums and educational institutions? Where is the point to which we start to make these changes? Are these anecdotal? Do we use anecdotal evidence to make these changes? How do we go about infusing these changes into the practice of what we're doing, of what we do every day? Those are some of the questions that we're going to have to ask ourselves as healthcare professionals. How do we take that tacit knowledge that we have going through this the COVID crisis and pass it on to some person who's new on the floor, who's just graduating, walking into an acute setting? How do we pass that tacit knowledge, that wisdom that we're taking from the COVID crisis? And how do we deal with the burden of the trauma that we're seeing and experiencing right currently on our floors, in some of our facilities, with our patients, and most importantly, also with ourselves? How do we mitigate these issues? Those are going to be some of the questions that we're going to have to find answers to as we proceed as a profession. So to transition us to our next slide, as we start to talk about the symptoms of trauma, I want us to think broadly about the symptoms, and not just from this sort of diagnostic perspective, because sometimes we have a tendency to isolate symptoms from feelings. And so when we do that, when we isolate symptoms from feelings, we start treating the symptoms and we stop treating the problem. So as we start to think about the symptoms here, I want us to really think about our symptoms in terms of feelings and how they impact us sort of in our daily lives. So some of the symptoms of trauma include anxiety and fear. And if you think about what does, and again, the reason why I say attach feelings to this, what does anxiety look like? What does fear look like? What does anxiety look like to a nurse who's walking onto a floor every day? What does fear look like to a doctor who's walking onto a floor every day to treat a patient? And what does it look like for a social worker, for a respiratory therapist? What does it look like? Does it look like uncertainty? Does it look like second guessing? Does it look like physical fatigue? Does it manifest itself through physical fatigue? What does it look like? Does it look like mistakes? What about game and guilt, shame, and self-blame? Withdrawing from others, isolation, feeling sad or hopeless, feeling disconnected. These are all the feelings of trauma. Numbness. And the question is, how do we then wrap our arms around someone who feels like this during times of crises? Particularly when we're in this heroic stage, when we're expecting so much of our healthcare professionals. How do we embrace this whole notion of anxiety and fear? Are we allowed to show fear? Are we allowed to show anxiety in times of crises? Those are some of the things that we will have to think about as a profession in terms of moving forward so that we don't have more stories of Dr. Brand. I know many of you are watching this webinar now are likely arriving at the conclusion that either you or someone that you know are currently exhibiting the symptoms described on the screen. And I would say to you, remember that these are all feelings. These are not symptoms, these are feelings. And no, I always told my patients that the absence of the ability to feel is numbness. When you reach that place of numbness, then we have to consider immediate options, right? Which takes us to our next slide. How do we mitigate the impact of trauma? First, it's important to note that there is a qualitative difference between mitigation and prevention. No one can prevent the pain and the suffering tied to the human experience, right? We know that that's just life. However, there are some things that we can do that can allow us to just have pain rather and not suffering on top of pain. So again, I always told my clients that pain is an indicator of life. I always told my clients if you don't feel pain, I told my clients that you don't feel pain when you're asleep, and you certainly don't feel pain when you're dead. So pain is an indicator of life. If you stop feeling pain, then it means you're dead, right? So pain is not necessarily a bad thing, but we don't have to have suffering on top of pain. So the question regarding how to mitigate the effects of trauma is it's the most difficult part of this entire journey of mitigating suffering and mitigating the effects of trauma. And the reason why it's the most difficult part is because responding to trauma is literally counterintuitive to our natural instincts. And what I mean by that is the natural response to emotional pain is what? Most of us do the same thing to pain, is we avoid it. The natural response to pain is simply to avoid it. We try not to have it. We either ignore it, we try not to have it, or we simply run away from it. And interesting enough, this keeps our emotional pain active and at the forefront of our minds. Because the preoccupation with that event tells the brain that the more we're thinking about this event must mean that there must be something here. So the brain thinks if there's not a threat, why are you trying so hard to not think or feel something? So desperately trying not to have an emotional pain, we inversely create more pain by virtue of our attempt to avoid it. So let's look at some of the protective factors on our next slide here, and then we can talk about how we can sort of mitigate some of the effects of pain and how we can start to inoculate ourselves from some of the suffering that we talked about in our previous slide. So let's take a look at our next slide. So some things we can do: protective factors, continuous contact with and support from important people in our lives. And I wanted to stop for a second because When we're having issues of pain and we're having anxiety, as we talked about in terms of we try to avoid pain, in some cases, what we do is we avoid people, which is counter to the protective factors. So in terms of continuous contact with and support from important people, we do the opposite. Disclosing the trauma to loved ones, we do the opposite. Identifying as a survivor opposed to a victim, sometimes we do the opposite. Use of positive emotion and laughter, finding positive meaning in the trauma. So think about this, right? So if we get to here later, I'll talk about a story that I tell a lot of my clients. We're talking about pain, but it's difficult, but it's so important that we find a positive meaning in the trauma. And one of the things that I would do when I was treating survivors of domestic violence is the first thing I would tell my clients is you can no longer consider yourself as a victim. You are a survivor. And once we start talking about framing how we view ourselves, it impacts how we then respond to that particular trauma. But also helping others in the healing process, holding the belief that you can manage your feelings and cope. Those are some of the protective factors that are very important to managing trauma. Next slide, please. And finally, we'll talk briefly about PTSD, this sort of last stage of this process, and then we'll sort of open up for questions. In our previous slide, we discussed trauma and protective factors that mitigate the effects of PTSD. I want to point out that the main difference between PTSD and the experience of trauma is very important to note, because a trauma is a traumatic event that's based on an amount of time, sort of shorter duration, if you will, where PTSD is sort of it's considered to be a long-term condition in which one continues to have flashbacks and re-experiencing the traumatic event over time. One of the closest points of reference that we have in terms of COVID is the SARS epidemic. And research during and after the SARS epidemic suggested that quarantine and fear of exposure to the virus itself had a serious effect on the mental health of healthcare providers, leading many of them to have mental health conditions, including PTSD and trauma. Results of the studies of those studies suggested that quarantine and isolation during the SARS epidemic predicted symptoms of acute stress disorder, depression, alcohol abuse, and brief psychotic disorder. Even 3 years later, quarantine was associated with post-traumatic stress symptoms, which were again more severe in healthcare workers than the general population. And as you would expect, as a result, many healthcare workers experience avoidance behaviors. Again, as I was talking about, going back to those protective factors, many of them experience avoidance behaviors and sought to minimize contact with patients, and some didn't go back to work at all. And so as the COVID pandemic rose into week 7 and week 8, again, I ask you, what impact might this leave on our profession? How will you step forward in this time of need? And in closing, we go to our last slide here. I'll tell you a story, and then I'll open up for questions here. And I always tell this story when sort of in large crowds and we're talking about trauma, but it's the connection between thinking and feeling. And I'll tell the story real quickly, and then we'll open up for questions. But the story goes that an EMT worker arrived at a very tragic accident scene. And upon arriving on the scene, he encountered this victim who was thrown out of his car, and his car was up on top of his leg, sort of crushing his leg and his body. The EMT worker found this lone survivor because he was screaming, he was hollering for help. And when the EMT worker found this particular survivor, the first thing he said to him, he said, "Sir, on a scale from 1 to 10, how would you rate your pain?" The survivor looked at the EMT driver and immediately started using profanity and said, "Why would you ask me about my pain? Don't you see this car's on top of my leg, fool?" He just sort of went to town calling him all these names. He said, "Why would you ask me such a dumb question like this if you see this car is pressing against my body?" And the EMT responded very quietly and said to him, he said, "Sir, if you are experiencing pain, and you're able to communicate with me, that means you're still alive. He said, I'm going to ask you again, on a scale from 1 to 10, what is your pain? And he looked at him and he said, my pain is a 10. Can you help me? And I always ask the question, why did the lone survivor calm himself? Why did his disposition become much calmer when he was given an example and when he was reminded that if he's in pain, that means he's still alive? And the answer is simple. Because during tragic situations, it's a matter of life and death. And what the EMT driver was able to do is connect what this individual was thinking. He was thinking, I'm in pain. He was thinking, am I alive, right? Is this real? Is this moment right now real? And he connected what he was feeling, which was the pain, which at one point was a bad thing. But once he was able to bridge and make that connection between what he was thinking and what he was feeling, the pain no longer was an enemy of his, it was his ally, because that pain was a reminder that he was alive. And sometimes that's what we have to remember to do in situations of crises and in times of trauma. As we were talking about finding meaning in the trauma, it's finding meaning in the pain. It's redefining the pain and the suffering that we feel and using that as a badge of honor, of resilience, opposing to looking at it as a victim in suffering. Thank you for your time. Thank you for your attention. I greatly appreciate it. I will now open the webinar up for any questions that you might have, any thoughts, any ideas you might have. I would love to discuss, share, and as I said earlier, this is just part one of a 2-part trauma series, which will be the other part 2 will be tomorrow, hosted by Dr. Jania Johnson on furthering managing trauma. So I'll open this up. Any questions, thoughts, or ideas, or comments for that matter? Someone said we need mental health availability, which is certainly true. And again, in many cases, we don't think about the mental health needs of our those who work on the front line. As I said with Dr. Brennan, all the PPE in the world unfortunately, couldn't have saved her from the dark days of her last days, unfortunately. It wasn't a matter of PPE. It was a matter of providing mental health and support during those times of need. Someone said trauma-informed care, and for all of us, these situations. Yeah, absolutely. It's understanding what is trauma-informed care and how does trauma-informed care, how do we integrate trauma-informed care into our treatment paradigm, into our treatment modalities. That's very important. When we think about treating clients, we think about treating the symptoms, and we think about this. We don't think about it in many cases as this sort of holistic version of treating the entire person, right? And so, unfortunately, we don't focus on the mental health. And again, in the cases of Dr. Brand and others across our country, we think about those physical attributes, the PPE. We think about those things that we can see, but we don't think about trauma. I often say that trauma is like carbon monoxide. It's invincible, but very deadly and very potent. Someone says we all will collectively bear the cost as communities, and I certainly agree. We all will bear this cost, and it's similar to the SARS epidemic. I think the effects of COVID will stay with us for a long time. I often say that uncertainty plus anxiety times fear, again, it's C4 in the boiler room. You can put a exponent on there as well, and you can easily see how it takes us into fight or flight. If you just think about just the parallels of uncertainty, anxiety, and again how it equals fear, and again you can put an exponent there, and you can see this is magnified times 10, how it takes us into this whole notion of fight or flight. And at that point, we're in this perpetual state of numbness, this perpetual state of this survival brain. And again, there's a cost of being in a survival brain opposed to being in a learning brain. All right, so I'm going to go ahead and conclude there. Again, thanks everyone for joining our webinar. We look forward to having you join our part 2 of this series. Thank you for your time. Thank you for your support. And again, continue to provide care for caregivers and continue to step forward. Thank you very much. Bye-bye.